Hi everyone, my name is Abby Ferdinand. I'm a PGY2 Oncology Pharmacy resident, and today I wanted to present on some updates for the influenza vaccination for this upcoming season, as well as talk about the optimal timing of vaccination in patients who are currently receiving chemotherapy. The CDC has recommendations that state that everyone who is 6 months of age and older should receive a vaccination against the influenza virus every season. There really are rare exceptions where a true contraindication or a time where a patient would not be eligible for the flu vaccine exists. Also, the CDC suggests that this year they have the statement that getting a flu vaccine is more important than ever during 2020 to 2021 to protect yourself and the people around you from influenza. It's important that we help reduce the strain on our healthcare systems while we are currently responding to the COVID-19 pandemic. As I previously mentioned, there really are few circumstances where receiving the influenza vaccine is a true contraindication. The one time that the CDC talks about a true contraindication would be if a patient received the vaccination prior and did have a reaction to the vaccine. There is typically mention about people who have egg allergies and if they are appropriate candidates for the vaccine or not. The CDC also does have recommendations for these patients. They list that people with egg allergies can receive any licensed, recommended, age-appropriate influenza vaccine. They also have a section where if people who have severe egg allergies, and they list that as those who have had any symptom other than hives after exposure to egg, they should still be vaccinated, but do so in a medical setting that's supervised by a healthcare provider who is able to recognize and manage severe allergic reactions. Here is a listed chart that has the available formulations of the influenza vaccine for this year within Monument Health. If you are interested, you can go to the CDC website and there is a full list of available products within the United States. But these will be the three that we have within our institutions for us this year. The first being Flulaval. This vaccination is approved for patients aged 6 months of age or older. Also of note, Flulaval will be the only influenza vaccine that will be available for our inpatients. Flucelvax is another product, and this virus is not egg-grown, so potentially could have benefit if patients are really concerned and do have egg allergies. This is approved for people who are aged 4 or greater. And finally, the Fluzone. This is going to be our high-dose vaccine, and this is approved for patients who are 65 years of age and older. It's especially important to ensure that our oncology patients are receiving their regular vaccinations and being protected from any infections that we can protect them from. Vaccination is especially important for these patients, regardless if they have current cancer and undergoing chemotherapy or other treatments, or if they have a cancer history. The oncology patient population is at a high risk for developing serious flu complications specifically. It is also important to educate patients that the influenza vaccine has a long, established safety record in the oncology patient population to ease any apprehension they may have about receiving the flu vaccine. The American Cancer Society also has some recommendations about vaccinating oncology patients. In general, there is some discussion on whether vaccinations given during chemotherapy or radiation treatments mount an adequate response due to the patient's compromised immune system. Regardless, the American Cancer Society always recommends that oncology patients receive their annual influenza vaccination. When talking about vaccinations, if they are live versus inactivated, oncology patients should receive an activated vaccine. The nasal flu mist is a live version of the influenza vaccine, and this is approved for patients who are aged 2 to 49 years. People with cancer should not receive the nasal flu mist. The American Cancer Society states that family members of a person with cancer may safely get the nasal spray, at least in some flu seasons. They also list recommendations, though this may not be appropriate if the patient has a severely weak immune system and or they are being cared for in a germ-protected area. For example, if household members are taking care of an oncology patient who has recently received a stem cell or bone marrow transplant, that caregiver should not receive the nasal mist. One of the most controversial things about administering the influenza vaccine to oncology patients is the timing. The IDSA and the ACS, or the American Cancer Society, they have recommendations that state to administer at least 2 weeks prior to receiving chemotherapy. The ACS also offers the option of vaccination between chemotherapy cycles. Primary data to support these recommendations is limited, however. In one clinical trial that was conducted in the 1970s, subjects with solid malignancies who received the influenza vaccine concurrently with chemotherapy had significantly decreased seroconversion in comparison with subjects who received the vaccine at the nadir of their white blood cell count. However, in contrast, subsequent studies have suggested improved influenza vaccine immunogenicity with the vaccine given early after chemotherapy rather than later after chemotherapy. Because of some of the contradictory findings on this topic, the optimal timing of administration for the influenza vaccine for our cancer patients undergoing chemotherapy is currently unknown. In addition, the risk of severe influenza disease is greater when patients are receiving active cytotoxic chemotherapy. So demonstrating an adequate or comparable influenza vaccine immunogenicity during this period would be of great benefit. Being this is a highly debated topic, there are quite a few trials within the literature studying this. This trial, conducted by Keem and colleagues, evaluated optimal timing of the influenza vaccine for patients currently receiving chemotherapy. Authors aimed to find the immunogenicity when the vaccine was administered concurrently with chemotherapy versus administered during the cytopenic period. And this was specifically conducted in patients who were undergoing 3-week chemotherapy cycles. This trial enrolled 97 patients, 61% of them had breast cancer, and 30% of them had lung cancer. Patients were randomly assigned to receive the 2014-2015 seasonal influenza vaccine on day 1 or day 11 of their chemotherapy cycle. Patients were stratified by age, previous influenza vaccination status, and measured antibody responses to the influenza vaccine strains H1N1, H3N2, and B before and at 21 to 28 days after vaccination. Results demonstrated that seroprotection rates after vaccination were not significantly different between day 1 and day 11 groups. For the H1N1 strain, 67% versus 75%. For the H3N2 strain, 77% versus 80%. And for strain B, 21% versus 27%, with none of those findings deeming to be statistically significant between groups. The one interesting thing, however, that was noted within this trial is that vaccine-related adverse events occurred significantly more frequently in patients who received the vaccine during the cytopenic period, 32% versus 13%. An important thing to note with this trial is that a majority of the patients were women with either breast or lung cancer. Therefore, the results might not be generalizable to other malignancies. However, this study is still of great importance to the clinical care of cancer patients because of the continued high incidence of these two forms of cancer. It's also worth noting that trends within the data suggest a potential immunogenicity benefit from administering the influenza vaccine during the cytopenic period versus the chemoconcurrent period. The authors finally concluded from this trial that larger and/or multi-center trials in all cancer subjects are warranted to determine the presence or absence of a benefit from influenza vaccination during the chemoconcurrent period versus the cytopenic period. Another study that I wanted to share in the oncology patient population is for those patients receiving the influenza vaccine while undergoing immunotherapy. This is a cohort study in patients with lung cancer receiving nivolumab, 3 milligrams per kilogram every 2 weeks during 2 influenza seasons, 2015, 2016, and then also the 2016-2017 influenza seasons. 42 patients received the influenza vaccine, while 85 patients did not. In vaccinated and non-vaccinated patients, the incidence of immune-related adverse events was 26% and 22% respectively. The incidence of serious immune-related adverse events was 7% and 4%. For patients who received the influenza vaccination while also receiving nivolumab, they did not result in significant differences in the rates of discontinuation, death, clinical deterioration, or tumor response between the two groups. Another study that I wanted to share is one that evaluated the dosing of the influenza vaccine, looking at the standard dose versus the high dose. In non-oncology patient populations, the high-dose influenza vaccine is recommended for patients who are 65 years of age or older. However, this study looked at oncology patients, and they didn't necessarily have to be age 65 or older. They could be younger. So this was a double-blind study that randomized patients receiving chemotherapy to vaccination with either the standard dose or the high-dose influenza vaccine, regardless of their age. The hemagglutination inhibition assays, or HAI, were performed prior to and 4 weeks after vaccination. HAI were summarized as geometric mean titers, seroconversion rates, and seroprotection rates. 105 subjects were enrolled in this trial, 51 received the standard dose and 54 received the high dose. Both vaccines were well tolerated and no serious adverse events were noted. Upon completion of the trial, 100 subjects had data that was available to evaluate. The seroconversion rates for all three influenza antigens and post-vaccination GMTs for H3N2 and B strains were significantly improved with the high dose compared to the standard dose influenza vaccine. Authors concluded that the trivalent high-dose influenza vaccine can safely be administered to patients receiving chemotherapy with improved immunogenicity and seroconversion compared to standard dose vaccine. Post-vaccination seroprotection rates were similar in both groups, and finally authors concluded that a larger study is needed to show clinical benefits with the high-dose vaccination in this population. Currently, the CDC does not list recommendations about the dosing for oncology patients. It would be recommended to follow what we normally do within the non-oncology patient population, with patients receiving the standard dose, and then if they are 65 years of age or older, they would qualify for the high-dose vaccination. In conclusion, it is always important that we vaccinate against the influenza virus, unless there are those rare contraindications. After watching this presentation, I hope it has shed some light on some of the debate of the timing of vaccinations, and that really the important thing is that patients are getting vaccinated, with maybe timing not be something that we worry so much about. We should review each patient on a case-by-case basis and do a shared clinical decision-making between the patient and the provider on what seems to be the most appropriate time to vaccinate that specific patient. Thank you all for watching this presentation. As always, if you have questions or would like to discuss further, I have listed my email there, aferdinand@monument.health. Thank you.